So, Leanne, let me ask you first. What are you keeping your sort of eyes on these days in healthcare? What's commanding your attention amongst the various things that might try to get it from you?
Well, no surprise. I think we're all very focused on common areas across the whole healthcare system. For us at Community Health Plan of Washington, Community Health Network of Washington, we've been focused on advancing health equity and really building on our model of whole person care. That's always been our focus, and it's more important than ever. The COVID has certainly brought light to the inequities in ways that folks just generally were not aware. So it's helped us have the impetus to take really strong action and to accelerate our efforts in ways that previously we were always focused on, but now it's at a much higher level of energy and urgency and commitment. So that's number one. It really integrates in everything we do. And when we talk about our whole person care model, it has many tentacles, obviously. We talk about integration with behavioral health. That's obviously top of mind, all the issues associated with mental health services and access. We talk about issues relating to housing and how we can provide integration between the medical and the home insecurity issues. And we also are thinking about how do we provide greater access in light of the really clear shortages that we are seeing across the board. And that's where promoting telehealth and working with communities to bridge the digital divide are other areas that we're focusing on. So all of this is, under the cloud of COVID and the need to really have a public health focus as well as our typical population.
So just for folks who may not know, correct me if I'm wrong, Leanne, the Community Health Network is the network of Washington State's FQHCs that form together, and the network operates or controls the Community Health Plan, that those are distinct entities. Correct. Yeah, good.
Yes, that's our parent organization for the health plan. 20 community health centers, federally qualified community health centers across the state of Washington make up our parent organization.
And so, Mark, down in Vancouver at the Vancouver Clinic, I wonder how you would say COVID has changed the work that you do in the community.
Well, DJ, we've been obviously on the forefront of delivering care during COVID. And it's really opened our eyes to the benefit of a population health approach, which we were enamored with before, but our integrated model really lends itself to that. So, besides, taking great care of patients during this pandemic, what we've really concentrated on is advancing a move to value. And we want to get paid for outcomes. We see the benefit of more of a per member per month kind of reimbursement system. We think fee for service is an old chassis that kind of needs to be retired. And I think, we have seen during COVID, we've actually opened several new clinics, which was a heavy lift, and then also opened a new approach to healthcare, which is a senior-based neighborhood clinic. So our Medicare Advantage patients and our DSNP patients now have access to a really focused model that delivers primary care in a very effective way and decreases ER visits and hospitalizations for that 5% of the population that consumes over 50% of the resources. So I think COVID's just, kind of accelerated all the need for that.
Yeah. And how about from where you sit, what has COVID reminded us about ourselves that maybe we knew, but we're so busy with life, maybe we overlooked? And by ourselves, I mean the healthcare system and healthcare sector.
A great question. I do think it's kind of taken off the rose-colored glasses a little bit, the sort of self-reverential nature sometimes that we hold our own profession in and the way we see our roles in it. I think in other ways also it's pulled us away, maybe, I hope, from the way we've defined health and care. So healthcare. I think that it's got to force us to think about the foundational aspects that really contribute to the opportunity for health or the propensity to be sick. And I really mean about the determinants that are really meaningful in people's lives, the things that people themselves say give them the chance to be healthy or not. That kind of broader thinking has to be driven in this time. The ways in which our ideas in the past, perhaps, that we could exist in our own little circles. I think before COVID, we were in bubbles in so many ways, really thinking that our own decisions were just affecting us and that we could make choices that seemed very, very personal and didn't have an emanating impact. And I think that has been shown to be an incredible falsehood, and that we have to think of ourselves as a collective group of people, that our decisions and actions really impact not only the people right next to us, but the people that we never meet. And until we start doing that, both in the healthcare system and I think more importantly across our communities, we are not going to be able to navigate difficult times. And we all know this is not the last difficult time that we will be going through as a society. Racism at the heart of so many factors that have affected so many communities in so many different ways. It's become an inescapable reality for folks, I think, who wanted to say that somehow it was not so much a factor anymore, that it could be explained by other factors. So I think about all of those things and maybe a few more.
Yeah, there's a lot of moving pieces here. Leanne, let me ask you, how do you bring an equity lens to the work at CHPW, and specifically to address institutional or more outgoing and acute forms of racism in healthcare?
Well, we approach this from a number of different perspectives. It's really our overarching strategy. And when we think about our strategy, we think about what levers do we have to pull. We think about it from the perspective of our internal culture and really advancing equity within our own culture and our understanding and awareness of the role that racism and other issues that prevent equity play in people's health. So it's really making sure that that piece is fully developed. And then we look at all of the other levers that we have, including our ability to work to reduce disparities through many of the quality improvement techniques. That's really an important part of population health and the work that we do. It involves our contracts with our providers and how we can learn together best practices associated with reducing disparities, in providing incentives for that, and ensuring that we have data that measures the right things so that we can see where there's opportunities to target specific interventions and improvements. So it's really cuts across all of the different areas that we have the ability to impact and to intervene.
Mark, I wonder if you could talk about how the Vancouver Clinic thinks about social determinants, specifically within the context of your work with seniors in Medicare Advantage. I might assume that if you want to get paid for outcomes, you're probably in some sort of capitated or hybrid risk-based payment model or something that is not straight for fee-for-service. So how do you think about social determinants and employing those, particularly with a senior population?
Yeah, we've very deliberately addressed that, DJ. As the reimbursement shifts to an outcomes-based, fully capped, sort of model, you have the ability to shift resources as needed. So we've learned from some people that have pioneered before us. I think of my friend Rashika at Iora Healthcare. During COVID, the first thing they did was deploy iPads to all their members so they could connect with their doctors. It was that important. So you wouldn't, running that through a normal reimbursement system would never work. When we opened our first neighborhood clinic, we embedded the folks from aging and social services. So there was somebody there to line up patients with Meals on Wheels, provide social support. We've embedded behavioral health, all those things that under a traditional fee-for-service delivery system would not be possible. So I think, you fundamentally change the way, moving from a volume system to a value system really allows one then to start to address social determinants of health. Now, I will say that we can't do everything. It's hard to line people up with housing and things like that. We're going to need to figure that out with other aspects of our community. But we've made some tremendous differences, and there's some wonderful stories out there.
Then I wonder how you think about, let me ask this kind of harder question, which is not one that I hear a lot of people talking about, which is what Mark kind of teed up there, which is, what are the limits of what the healthcare system can do in the space of social determinants? I know you've been involved with the Group Health Foundation board. I think they're doing a lot of great work. It's sort of healthcare adjacent insofar as it's a healthcare philanthropy organization. I'm wondering where you see the sort of limits of healthcare service delivery in addressing social determinants, and then what comes after that?
I appreciate that question and this line of conversation. I think it's so important. I'm going to open with just something that'll make me sound a little Pollyanna in some ways, but I think sometimes we've done a disservice by thinking first about what we can't do instead of really trying to imagine what we can do. And I'm looking forward into the next year, 5 years, and 10 years, and the recovery, however you want to define that this society is going to need to go through, and especially the risk that recovery will leave so many people behind like it has so many times before. And what I want to think about is what is the boldest stance that we can take? What is the greatest imagination that we can pull into this work? What are the things that we've learned from already that we could be developing with greater vigor, greater ardency, and greater imagination? I think about medical legal partnerships that were created that allowed, this was working side by side with lawyers that knew the civil legal stuff and doctors that knew the health stuff, and how the combination of those uncommon partners created just incredible opportunities for solutions that wouldn't have been there before. And it wasn't a huge, not a cost add, not a major diversion from other kinds of efforts. And yet, if somebody hadn't talked about, I wonder what it would be like for me to think a little bit beyond the usual letters that go after the names of the usual people that I work with, could we do something different and better? So I guess I'm calling myself in on this, to be honest with you, DJ, to be as expansive and bold in thinking as possible, because what we risk right now is a limitation in imagination and courage and will. That's the greatest risk to our healthcare system and to the health of the people that we care about around us. I drifted a little there. So
no, it's great.
In the fold, I'm willing to.
No, I was just thinking to myself, this is why I invite Ben Danielson on to come talk, is because you call us to our better angels and remind us that it takes collaboration, it takes cooperation, and it takes courageous visionary activism to solve some of these problems. Leanne, how about you? Point to, if you would, are there specific things that CHPW has done in the way of social determinants where you have moved beyond healthcare service delivery alone and gotten much more innovative, and now have some, case study or maybe some anecdotal stories that you can share for others to follow?
Sure. Well, first of all, I think part of the system's limitations that we need to think beyond is that short-term, the concept of a short-term ROI. That's so limiting, and it's a problem of our society more generally, right? I mean, we really need to think about the value that we'll see over time, to Dr. Danielson's point. And so when we think about our impact and what we can do, we really have the advantage of not just thinking in the short run for the most part, because we are a not-for-profit that's governed by FQHCs, and it is our mission to improve the health of people and their communities, and it's the mission of our parents of each of the CHCs as well to have that broader goal and aim. So when we work together, we are often embarking on efforts that doesn't necessarily directly impact the bottom line of our health plan. In fact, it hurts the bottom line of our health plan many times, and it also helps our competitors, if you will, because it's helping people that go way beyond our own health plan's members. And we can do that because that's our surpluses go to our community health center parents. That's where our any surplus goes, and that's how our payment mechanism is set up. So we support our community health centers in many very specific direct ways associated with SDOH and housing, for example. We have community health centers that are very directly involved in providing transitional care, for example, respite care, working with counties and local healthcare housing authorities to provide that integration between medical, physical, and other types of services within a housing, public housing opportunity. So we support that in a variety of ways. And we're developing a strategy that takes advantage of our network and the scale that we have and the resources that we have within the health plan to advance those types of efforts even more. And we know that that directly improves the health of the individuals that are involved.
Chpw is, of course, unique in Washington State, but also nationwide, unique in terms of its structure, payer and provider structure. Mark, as a provider, we have a question from a payer. Claire Verity is the plan president at Regents Blue Cross, and she says, Mark, thank you for being such a visionary and bringing increased access to care. I'm wondering if you can expand on your thoughts on payer-provider collaboration and what elements have worked the best to achieve a balance between care access, reimbursement, and experience. Mark, what do you think?
Thanks for the compliment, Claire, and the question. I think there's tremendous opportunity going forward. We've done a lot of payer collaboration in Southwest Washington with our major payers, Regents, Humana, and United. And I think coordinating, who's really going to be most effective in delivering that population health approach. The plans have a lot of data that can be very helpful to a responsible medical group then in terms of doing outreach and sophisticated population health. One great example was the first day we opened a senior clinic. One of the first patients of the day needed compression socks. And normally that would be a huge undertaking in terms of a referral and getting it approved and blah, blah, blah. Because of the arrangement we had with the insurance company, the patient was walked over to the rep who was in the building, and the stockings were delivered the next day to that patient's door, and we made sure they used them. So I think it really comes down to saying, okay, we've got this pot of money to work with, and how are we going to best divvy up the responsibilities? And I just think there's, like Ben said, just incredible opportunities for innovation there. We spent, to borrow from our good friend Governor Kitzhaber, we spent enough money in healthcare. It's just misallocated. So, if given the opportunity to kind of reallocate that stuff, we can do tremendous things.
There's a rumor going around that Governor Kitzhaber may be running for governor again here this year in 2022. So stay tuned for those of you down in Oregon or near the border. Rhonda Hoff says, outstanding example, Leanne, housing and medical respite care is a great one. Laura Hawkins, I'll pose this question from Laura to you, Ben, because it builds on comments that you already began. She says, how do we best collaborate with with the community? I just lost that there. Somebody bounced around and somebody upvoted it, so it went higher. how do we best collaborate with the community and other healthcare organizations so we are not working in silos or recreating the wheel, specifically about integrating healthcare and the community to address health equity? Ben, further thoughts on how you drive that collaboration and build those cross-silo linkages?
I think there's a lot of exciting ideas and opportunities out there. And as a pediatrician, I think about the pathways and ladders and ways in which young people can be part of the healthcare system and work into and through different kinds of pathways towards fulfilling careers and work. I really wonder about continuing to work very hard to extend into this space of community health worker and really make that an integrated effort between the existing healthcare networks and systems and the communities that they serve, and really be driven by the perspectives of those communities in terms of how they would like those community health workers to look, what kinds of training and skills, and how to make sure that those workers are actually coming from those same communities that you're serving. It seems like a small thing perhaps, but I think it's really transformational in making healthcare feel something that's much more connected to communities, that it has a language and a culture and a face to it that looks like the person that you would feel is trustworthy, trusting, and connected to. And I think it starts to make destinies much more commingled when you have that kind of strength of workforce, early workforce, developable communities, and a sense of shared purpose. So that's just one thing I would point to.
How do we, Ben, sticking with that line of thought? I think across every demographic, I don't know this, I just know in many demographics that are not white, we don't have as many caregivers who look like communities, particularly people of color, to match the proportion of the population. So we don't have, in Washington State, I think there are 13% of our state are of Asian descent, and we're less than 13% of caregivers who are of Asian descent. So how do we build a pipeline, particularly since you are at the university working with kids and talking about workforce, how do we build a pipeline that is bigger so we catch more people of color so we can move them through that pipeline and get them to provide care in their communities?
I don't think it's actually all that complicated or hard. I do think it takes the kinds of perspective that both Leanne and Mark are talking about seeing the bigger picture and looking a little bit longer term. I do think it takes really being intentional. And if this is a deficit, if this is a problem, then you need a solution that's oriented to this problem. We've created barriers to having solutions that drive towards this problem. Barriers like Initiative 200 and other forms where it's hard to actually go straight at this problem in different settings. We need to actually say that if we want to see, if I want kids to see somebody who looks like them as their provider, then I need to start cultivating, training, promoting, encouraging, and developing those pathways. It's actually not, I don't think it's a challenge. I think from an ROI perspective, I think it's an incredible return on investment. I think that the service you provide, the data around better outcomes for care, when just in that simple way, somebody looks like the person that they're providing care to, and in the sustainable and enrichment of communities around you, which we are all anchor institutions in support of. I think the ROI is pretty clear on that. This is one of those where this is more about will than I think it is problem solving if you really got down to it.
It's a great point. So many of these problems are about will, maybe resource, but I guess that's a question of will also. Mark, I wonder how you go about recruiting or thinking about your own workforce at the Vancouver Clinic, and how intentionality about recruiting people of color comes into those efforts.
Mm-hmm. Yeah, I love that word intentionality. I think that's spot on. So thank you, Ben. We, on the physician side, we're doing pretty good. We have recruited quite a diverse workforce, and I'm very proud of that. There's a lot more to do. And I think, it's getting to the high schools, early on, offering internships in the various nursing and MA programs, et cetera, that we're pretty involved in. And we formed a DEI committee that is really working very hard to put together a very detailed plan on being intentional about this and setting goals and having our whole organization support that. So I'm pretty encouraged.
I know one of the data points a colleague of mine shared with me recently is that based on their internal work and their internal research and their survey of other research, that if you don't take a kid and tell him or her by fourth grade that they can be anything and plant the idea that they might be an astronaut or they might be a doctor or they might be an engineer or whatever, if you don't plant that by the fourth grade, then they are very unlikely, extraordinarily statistically unlikely to ever get there, to ever want to pursue that. You got to get to them by the fourth grade, and that we don't have enough people of color telling those fourth grade kids what they can be. There's a lot to this conversation. I want to make sure that we are respectful of everybody's time. I want to go through each of you, and Leanne, I'll start with you. What gives you hope as you look out at 2022? We have all of these problems. We have all these great challenges. We have so much wind in our sails moving forward. What gives you hope that we can knock some of these big issues back, if not down, this year?
And I'm probably going to repeat what a lot of folks have said, because I think it is at the crux of what gives us all hope, which is the ability to work together towards a common goal. And I think there's more of that than there ever has been before in not just the healthcare industry, but in its adjacent spaces, and working together with the community-based organizations and other community stakeholders and the government. The public sector has been incredibly aligned with all of us around these goals. And I take a lot of comfort from that, and it's inspirational. And what it comes down to for me is that we all have a role to play. We all can do something to push things in the right direction. It feels daunting, of course, when we look at the problem and how big it is and how immense it is and how long-standing it's been. But if we can think about what can we do, what's our role, where do we have power of some kind to change things, and how do we do this together, working collaboratively? That's what keeps me going.
Mark, what gives you hope in 2022?
The power of community. I can tell you that during COVID, we met regularly and deliberately with public health, with our hospitals, and really pulled together. And I'm very proud of the response that was put together in terms of testing and immunization and everything else. And I think that just shows the power of what we can do when we tear down those silos and really work together. So I'm very hopeful that will continue, and we'll see our healthcare system really take even a larger role in improving overall health, not just medical care.
Ben, we'll give you the last thought on this. What gives you hope in 2022 as you look out on the road ahead?
Oh man, DJ, I'm a pediatrician, so whenever I see kids, there's an inescapable level of hope that is present in every one of them, and it turns that hope actually into expectation. So what gives me expectation for something different is even more powerful than what gives me hope for something different. And to see that positive energy, to see young people starting to come up into this field that aren't tolerating the kinds of things that I'm embarrassed to say I think I tolerated in the way people had treated each other, whether it's gender bias or racism or other forms of really indignity. I think I get great hope and higher expectation by the way I've seen collaborations come together. And the one example I wanted to name was this vaccine collaborative that the Department of Health put together, where 600 different groups of people from around the state with many, many different interests who would never have talked to each other about their strategies and goals before came together to talk about ways in which to make sure that we got through this pandemic as well as possible. And the ideas and the energy and the sharing and the joy and the laughter and the ways in which people found themselves stronger because they saw each other and saw the ways in which our destinies are tied together. Those incredible experiences. So even in this frame of two-dimensional screens and Hollywood Squares kinds of interactions, I think that when we see each other and when we see what's possible because of what we're able to do, when we find the times where we can smile and be silly and have milk coming out of our nose kind of laughter in the midst of some of the hardest things possible, that has to make you think that nothing is actually impossible in this time.
Dr. Ben Danielson, clinical professor at the UW School of Medicine, Leanne Burge, the CEO of Community Health Plan of Washington, and Mark Manti, the CEO of the Vancouver Clinic. Thank you guys for doing this.